Hey guys, I'm Robert Libbey, registered massage therapist and instructor of ligamentous articular strain technique. Thank you so much for being here today. Today I've got a very interesting story that is from my practice from about 10, 12 years ago. And if you guys remember from last week, I posted this image to social media just to grab your attention. This is a patient of ours from our office from about that 10, 12 year period of time. And the story of how this image happened was that he was out for a boys' weekend, out all-terrain vehicling, ATVing through the forest, the rocks and the trees and the roots, and he went over a tree or a rock into a ravine, and when he landed, the all-terrain vehicle was nose down into the dirt, and his hand was on the handlebar, and the force of impact at the end caused his humerus to keep going when the all-terrain vehicle and his forearm and his wrist stopped. So he hit the ground and the humerus actually kept going. So as you can see, there's quite a lot of derangement of the humerus, the olecranon, the anterior, medial, lateral aspects and posterior aspects of the humerus. And what I'd like to do is just run you guys through a little bit of some anatomy. So here we have the humerus, we've got the radius, we've got the ulna, we've got the ulna, radius, and humerus all through here. We've got the proximal head of the radius, we've got the annular ligament that surrounds the proximal head of the radius and attaches onto the olecranon. We've got the radial-collateral ligament that blends in with that annular ligament and provides some stability for the lateral aspect of the elbow. On the medial aspect, we have the ulnar collateral ligamentous tissue. And as you can see, we get a little bit of flexion and extension that occurs. We've got the anterior structures, but in the posterior structures are the ones that I want you guys to really think about. We've got the olecranon process, and we've got the olecranon fossa that is a hinge joint, and it allows us to go from having a little bit of a flexed elbow to going into a full extension. Now, depending on the depth of the olecranon fossa will determine if you have extension or if you can go into a little bit of hyperextension, or maybe it's just that you don't get the full extension to begin with. So I want you to keep that in mind. Now, with his injury, he obviously required some surgery, and I was privileged enough in order to, well, I was able to acquire his X-rays post-surgery. So let's run through those images. So here we have the first image where the plate and the pins have been inserted into the humerus and the olecranon in order to stabilize the structures and the various bits and pieces of bone that are now free to move around. This is a lateral aspect. Here is a posterior aspect where you can see that the plate and the pins have been inserted. They've done a really nice job of collecting a majority of the bits and pieces that were fractured, and they're set up to unionize quite nicely. We've got a little bit of some bone fragments that are off to the side that they chose to leave in there. This is another nice image just showing that the plate is nice and straight, the pins are inserted, and all of the parts are collected. Now, he was receiving rehabilitation from us as massage therapists, but he was also seeing another medical professional for rehabilitation services, and I won't say who the medical professional, what medical profession they were from, out of respect, because it's something that is widespread throughout all professions. And one thing that is concerning is that a lot of us can tend to get into tunnel vision, and we recognize what the normal available range of motion is, or functional range of motion is for a normal joint, but when we've got a fracture, we tend to have this need to reacquire that full range of motion for that patient because we want them to have the best quality of life that we can provide them, or that we can help them on the route of getting to that place. What a lot of people tend to forget, though, is that the structure has changed. It doesn't matter what type of fracture, if it's a avulsion fracture or a spiral fracture or a comminuted fracture like this, the structure has changed. And therefore, we have to change our expectations and help the patient change their expectations as to what a new normal looks like. The new normal range of motion for this patient was not the full range of motion that he had pre-fracture. The therapist that he was seeing didn't recognize that. And that therapist was very, very goal-driven to reacquire the pre-fractured full functional range of motion, which she got in one treatment. But she got it at the expense of risk of harm to the patient. Now, this patient had seen that medical professional for that treatment. She had done or performed the technique in order to acquire the full functional range of motion that was what he had pre-injury. And he came into our office and his arm was 3 to 4 times the size that it had been the previous treatment. After him telling us the story, we immediately referred out to the hospital. And these are the X-rays that they took at the hospital right after we referred him to them. As you can see, the plate and the pins are no longer in the position that they were in post-surgery. There is space that is created between his bone structure and the plate, and the pins have been pulled out of position, and the plate is actually no longer straight. Here's a nice close-up showing you the gaps that are now in place because of the range of motion that she had attempted to try to acquire. And as you can see from this image and this image, that not only is the plate bent in an anterior-posterior position, but it's also bent in a lateral position too, and that the bone fragments are no longer as nicely connected as they were before, because again, when she bent the plate, she also pulled the pins which were attached onto the bone structure. To give you a comparison of pre-injury from the therapist and post-injury from the therapist, pre-injury, the plate is nice and straight. Post-injury, it actually has 3 angles to it. And here is post-injury again, with the lateral angle that has happened to the plates and the pins. So again, recognize that structure has changed and that hardware also is a limiting factor in acquiring that full functional range of motion in those joints. Now, I don't have the X-rays of his second surgery that he required in order to remove this bent hardware, but I remember seeing the X-rays. The X-rays showed plates and pins that were at least double the size that were put in place in order to stabilize the joint even that much more. I do have his X-rays in this image of when the hardware was removed. At some point after the second surgery to correct the injury from that therapist, his body started to reject the hardware. They removed the hardware, and this is what his structure looks like. So once again, if you look at the olecranon fossa, the medial lateral condyles, even the shaft of the humerus, it doesn't look normal, and our expectations of acquiring a pre-injured functional normal range of motion need to be removed. We need to be happy with whatever range of motion we can get that is pain-free and functional for that patient. And we also need to educate our patients as to what their new normal is based on what the structure looks like and what the hardware that may or may not be in place looks like also. So I hope you guys enjoyed this video. I hope it was educational for you. I hope that it makes you stop and think and slow down in your practice and not be in such a rush to get your patients on the table, not be in such a rush to try and gain as much functional range of motion with that patient in that hour as that you can. You need to slow down, investigate, ask questions. If you can gain access to the X-rays like I'm able to gain, or even gaining the reports for the surgeries, those are also really important to gain. You know, pictures say 1,000 words, and these images are absolutely fantastic to have. You know, it allows us as therapists to know what we can do and what structurally is not going to be available to us in order to get for that patient. So, slow down your practice. Don't have tunnel vision. Take your time with your patient. Get as educated as you can about the injured site. If you don't know your anatomy, then review your anatomy. Review your anatomy with your patient. It's great for patient education. And really just take your time, slow down, and do the best possible job that you can. Be as competent and confident as you can in your skills and your knowledge, and in the time that you're taking as a professional to educate your patient and yourself about the injuries that they're coming in with. Hope you enjoyed the video. I hope it was educational for you. If you'd like to see more of these videos, please subscribe to my YouTube channel. Also, head over to lastsite.ca. That's where I post a lot of research articles pertaining to ligaments, joint capsule, fascia tissue, neurological tissues. And thanks for watching. I really appreciate you guys taking the time out of your life to watch the video. Hope you guys found it educational and enjoying. And I will see you guys next time. Thanks, guys.